there is a lot of interest for the approach with combination target therapy, immunotherapy. Why this? Because we have a treatment, target therapy, with a higher response rate, and we have a treatment with immunotherapy with a lower response rate but durable response. So if we can get high response rate but with whole response, durable response, of course, would be great. And this, of course, for several reasons. Moreover, with the BRAF and MEK inhibitor, we can also activate the immune system. So we can have also an immuno-mediated mechanism of action from this. So this can prepare, of course, the field for checkpoint inhibitor action. So let's say, that there were several phase 1 trials with 3 different triplet combination with vemurafenib, combination atezolizumab, dabrafenib, trametinib, spartalizumab, and dabrafenib, trametinib, pembrolizumab. Last year, here at ESMO, we had the data from the phase 1, showed 73% response rate, duration response more than 19 months. It is more than with target therapy alone without PD-1. Safety profile was interestingly toxic. 70% of any grade 3 and 4 adverse event, and the 40% of patients discontinued for toxicity. But this was the phase 1. Now at ESMO, we presented the data from the part 3 of the KEYNOTE022, that is the randomized phase 2 study, which compared dabrafenib, trametinib, pembrolizumab to dabrafenib, trametinib, placebo. So this is the first report of a randomized study for the triplet. And in this trial, we enrolled 120 patients, 60 per arm. And it's important to consider the study design, because the design was really ambitious if we look to the power for the progression-free survival, because we designed the trial considering to get an hazard ratio of 0.62 or less in order to get significance. So this was the design of the trial. That said, another important consideration looking to the patient's characteristic. In this trial, we enrolled more patients with elevated LDH, that are the patients with worst prognostic factor. Was 43%, too hard. Consider that in general, in this kind of clinical trial, this percentage is 34-36, so it was higher. And more, if you look, the M1C group was more than 80% in the triplet arm with pembrolizumab, and 60% in dabrafenib with placebo. So more patients with visceral disease in the triplet. This is important. But looking at response rate, similar. Interesting, a little bit more in dabrafenib with placebo than not the triplet. But this can be explained, of course, with the number of patients enrolled that is not so high. More complete response in the triplet, 19 versus 11%. This is interesting because if you look the waterfall plot, in the triplet we had a higher shrinkage of the tumor, more patients with more than 60% of the shrinkage of the tumor compared with dabrafenib without placebo. If we look to the progression-free survival, it's interesting. The median PFS was more than 16 months in the triplet, 10 months in the dabrafenib, so 6 months more with an hazard ratio of 0.66, 34% of risk reduction. And if you look at the curve, it's interesting to see that the curves are similar in the first 6 months and then start to be separated. So the response rate is similar, but probably the action of pembro was important in order to increase the level of the progression-free survival. And looking to the median duration of response was still higher in the triplet, median duration more than 18 months in dabrafenib pembro, and was 12 months in dabrafenib alone. But because the statistical design was ambitious, as the ratios less than 0.62, so the study cannot be considered significant. But for sure, it's interesting with an interesting progression-free survival. Overall survival. If you look overall survival curves, the curves seem really similar. So hazard ratio is 0.77 and not significant, and the curves are pretty similar. But there are some consideration. The 1 year overall survival rate 79% the triplet, 73% the dabrafenib trametinib with the placebo. 73% is exactly the 1 year overall survival of dabrafenib trametinib in the previous study. 79 in the triplet is the highest 1 year overall survival rates reached in a clinical trial. So this is interesting. And probably we should look also with a more follower, because at the moment the median follow is 9 months, is not measured, in order to see the tail of the curve. Because maybe that with the combination we can get more durable response. But there is another important consideration. If the two curves are similar, like seems to be, and looking to the post-progression treatments, more patients, 40% more patients were treated with immunotherapy after progression with the BRAF and trametinib. So what does it mean? This means that probably we can see a comparison between combination versus sequencing. So we can still reach good outcome even with the sequence. But if we look at the forest plot, if we look at with the triplet, we got more benefit in patients with elevated LDH and performance status of 1, probably the triplet may be for the patients with a bad disease. We'll see, because an important consideration, safety. The safety profile confirmed what we have seen in the phase 1. So the impact of grade 3 and 4 adverse event treatment rate is 53%. 40% of patients discontinue treatment, so toxicity may be upon. One that was registered in the triplet for a pneumonitis, and if you look the safety profile, liver toxicity and pneumonitis were the cases of the discontinuation for treatment. So again, these two side effects may be tricky. So in conclusion, for sure, the triplet showed interesting results. Probably not be for all comers. Probably could be in the future for the patients with bad disease, brain met, elevated LDH, and high tumor burden. We'll see. But for sure, I can comment also some data that yesterday we have seen with the PEMBRA study. That is the Dutch trial with a sequencing approach with pembrolizumab, dabrafenib, trametinib. So with pembrolizumab, dabrafenib, trametinib given sequentially, the PEMBRA showed the same response rate with less toxicity. So this may be in the future something that we can consider if we want to give the triplet for all comers.